So this is my team. My name is Marco. I'm originally from Germany. I studied there. I finished university 2002 in Hamburg and did my master in oral surgery 2007. I had the chance to work with really great people in this time and moved to Switzerland 2009 and built up a small clinic from scratch 10 years ago. I'm working now for many years in the field of surgery and implantology, but I'm a general dentist, but my focus and my passion is all about surgery and implantology. So the topic for tonight is, like you saw on the paper, on the advertisement, wherever it is, my journey. And before I start to dive into the topic, I have to tell you a very short story. This year, I was invited by EthOss to come to 2 days to London for hospitation at Peter's place, and it was really cool. Nice inspirational talks, lectures, and I was using their EthOss for about 2 years. So, and we had a good time. And when I came back to Switzerland, I got actually a message from Joe from EthOss, who asked me if I would like to talk about EthOss, giving a lecture. I said, yes, cool. Of course I will do. And the problem was just the schedule, because the schedule, like we have today, it's autumn. And in June, where I get the message, I didn't, thinking about lecturing on EthOss. So I didn't collect any cases because I was lecturing only for Dentsply Sirona in the past. So I was not collecting cases in the last 2 years about EthOss. So my idea was just to give you, let's say, sharing you some knowledge of my journey, where I started with augmentation and how is it today. So part one is just, let's say, a little bit bigger part. This is all the thing I done in the past and some basic considerations as well. And just let's start, okay? So now we see some multiple techniques and protocols I used in the past, also with the corresponding materials, and it was a lot of different stuff you will see. And my journey started 2004. There I placed my first implant with a little bit of augmentation, and my journey started. And when we start with a journey and we have to ask ourselves what kind of materials we use, what kind of implants we use, whatever, treatment planning, we are looking for, let's say, some requirements the materials should give us, that we have a better stomach feeling. So, and of course, if you are maybe a young dentist or young surgeon, you are listening also to your mentors and the place where you work at the moment. And if you also look in the literature, you will see every time the same, let's say, needs and requirements we want to have for our products we use in the jaw of our patients. And so materials should be safe, they should be easy to use, predictable, you know, all this. Hey, Peter. Hey. Hey. So it should be stable and of course should be biocompatible, you know, and fully resorbable. This is a big point, so we'll come to this later. Should be some osteoinductive components inside and also osteoconductive components. So this is the things we have to know or we want to have, okay? So, and when we are looking for this and we are looking for the best technique, the best protocol, it's a quest, okay? So we start in the beginning, we are searching for something, we listen to lectures, to our mentors, and then we make a decision to start. And my first implant was in the lower mandible, and the mandible, frontal tooth with a little bit of augmentation on the buccal. And I used some bovine material and some membrane on top and some titanium tags. And this is also the first part of our lecture tonight. So we're talking a little bit of GBR and bovine materials and all these nice membranes I used in the past. I think you will have also nearly the same journey like me. This is the way we start. So we talk about GBR and we're talking about bovine materials. But before we talk about bovine materials, so I didn't use this kind of techniques for a longer time now, so I don't want to share any cases with you, but the ideas behind it. And maybe if you talk about GBR and bovine materials, we have to listen to one of the big masters of bovine augmentation, and this is Istvan Urban. This is an interview recorded at the EAO 2017. Let's listen to him.
You talked about regeneration here at the EAO Congress this year. Can you tell us something more about your presentation?
Well, my topic was the use of membranes and bone substitutes for regeneration. So I started out with the traditional guided bone regeneration concept, which was with the membranes that were mainly used for single teeth with defects. But right away, we went into defects such as big vertical deficiency in the posterior mandible, big vertical deficiency in the anterior maxilla, horizontal deficiency even in the edentulous maxilla, using membranes and bone substitutes and some autogenous articulated bone that was collected in the oral cavity. So I presented cases that were before not possible to do without hospitalization of the patient, without hip grafts, calvaria bone grafts. And today we can do this in an outpatient surgery, intraoral, much less invasive.
What do you think about it? In a few points, I give him right. I think the advantages we now have with bone graft materials and bone substitutes to avoid these huge surgeries with harvesting bone from some parts of our body is perfect. So, and in this point, I give him totally right. I don't think so. This kind of techniques are good for the long term, but I come on this point for later on. But to have in mind that we can use also, let's say, bone substitutes and easier approaches to solve big problems. I think this is the key message. And for this message, we should be thankful for him and also for the Danny Boozers in the past, even if I don't believe everything they say. So now we see here a slide from the Geistlich website where we see the sausage technique of Istvan Urban, where he mixed up bovine material with some autogenous bone and fixed everything with a collagen membrane and some titanium tags. We can achieve big volumes with this technique, and I did. And but every time I do the re-entry or try to place my implants, I think it was never looking that good like on the congresses on the main stage when we see the videos and the slides. It every time felt different. It was not really a vital bone I was using my burrs working on it. So it felt not every time really good. Of course, the failure rates were not super high, but after a while, and now I left university nearly 20 years ago, and I saw now I can say a few cases. And after these years of treating patients and having second opinion patients on my chair, I saw a lot of cases like you see here on the left. There's a picture I got from Peter. You can see an implant which is not in bone. It's like in something, some popcorn or whatever, but it's for me, this is no bone. And to see it in the bigger picture, I removed so many implants and placed in a, let's say, so-called bio composite piece of something, piece of dead cow. And I saw so many problems that I quitted working with this and this kind of materials. So I'm not happy with these outcomes. And also when you see this picture here from a jaw, what you can see here, this is absolutely no bone. This is just, for me, biotolerated hard material. That's it. Nothing more, nothing less. So I don't want to have this kind of piece in my jaw, and I don't want to place this in my patient's mouth anymore. In this routine, we are heard so many lectures about it. So I recently also had a paper in my hand from Michael Norton, where he saw a very bad case of a huge inflammation in the sinus after completely finished surgery. I think it was 8 years after surgery, such a long time. And after this huge inflammation, osteomyelitis, big problems. So this can also happen after years. And this made me think, and that's why I'm not very happy about it. So sometimes when we use lots of these bovine materials, it can happen that you have just cows. And I like this comic from Gary Larson very much because it reminds me completely on the story. So I just wanted to share it with you. I still have indications for bovine materials, and please don't get me wrong. In some cases, I really love bovine materials. For example, as a tomahawk steak, maybe you have a big green egg at home, just use some herbs on top, some olive oil, you're done. Or you can have some herbs. Or some ossobuco, smashed potatoes, a little bit of truffle, then you're done. Good red wine for it. That are my indications both for bovine materials today. So next point, next step, you go to autologous bone. This is quite a big part of my life. So I was working with my uncles and he invented such nice techniques like the bone ring technique. So autologous was like, for some part of my life, my way of harvesting and do augmentation. This was my routine. So, but if we talk about harvesting bones somewhere, we also have to talk about anatomy. Of course, for many of you, this is just super boring. The slides from university to see some places to harvest bone. But I just wanted to share you the slide where I harvested bone and where I had the best results. So I mainly harvested bone from the chin, not so much from the retromolar area, sometimes from the tuberosity, and more often from the palate, because the bone quality at the palate was the best. And for this techniques, I will show you now later on, these were the places to harvest bone. When we go for the retromolar area, of course, we have quite a big amount of bone, but we only can collect quite thin plates of cortical bone, and there is no spongious bone underneath. So it's not very bioactive. And this is maybe a good place to harvest bone for the curry technique, but not for the techniques I used. So and when we harvest here bone, this is from a body from Vienna University, where we also did courses in the past. You can see the bone plates are quite thin. And underneath we have good friends like this nerve here. So it's quite, it can be dangerous, also not very experienced surgeon, but it can be dangerous to harvest bone there. And I also saw, it's now a very nice, interesting lecture on the EAO in Geneva. A guy from Italy showed how to harvest bone from the retromolar area guided. It was quite interesting. But in the end, I never used it so much just because it was not the kind of bone quality I was looking for. Okay, and on the lingual part, we have also another nerve. So there's a kind of danger zone and we can avoid it. It's not necessary at all. Okay, so here's the nerve, okay, quite thick. Then we have a look from the anatomy on the chin, because the chin is like a little bit, people are talking about, if they hear chin and they're hearing harvesting, they talk about paresthesia. This is the biggest thing, paresthesia. I never had one, but the reason is how you use your scalpel and how you do your incision. So when you look into our textbooks from university, or even books are printed today, they show completely wrong incisions. You can see here the three main branches from the mental nerve from both sides. They come to the front. And of course, if you do an incision, a wide incision with the vertical incisions as well, you will cut one of these branches. So, and then afterwards you have the paresthesia. It's just logic, okay? So, but if we want to harvest chin from the bone from the chin, I went for the T incision from canine to canine with a central vertical incision. I never had any problems with paresthesia. So when we had cases maybe, or the first cases where we start with bone block augmentation, it's most of the time this small, let's say, gap here, defect, thin, where you just place a small bone block and fix it with some screws. nothing big. Okay, so fill up the voids with some bone chips maybe, and of course cover this with a membrane. This was highly recommended. This is the place where you start with bone block augmentation, and I did as well. So highly predictable, working good, but you have to harvest somewhere bone. That's it. So my first bigger case, let's say, and a very challenging case with this technique is also one of the cases where I have the longest follow-up because the patient is still coming to my clinic. And it is a really challenging case from 1-1 and 2-1 with big defects. And of course, he wanted to have an aesthetic reconstruction. And when you see the X-rays, okay, aesthetic reconstruction is, yeah, it's good. I understand it, but it's very hard. Okay, but let's have a look at it on this case. Okay, you can see here the X-ray. It's quite old with 1-1 and 2-1, and you see here we have a major problem. Okay, so there's absolutely no bone, and also the soft tissue was looking really bad. I removed this both tooth, worked with a temporary for 8 to 10 weeks, and then was my idea to harvest 2 bone rings from the chin, do the 3D augmentation and the implants at the same time, to do everything just in a one-step surgery. So I went to the chin, use a tree fine to mark a position for, let's call it bone ring. I don't want to have a deep dive into the topic now because we don't have the time for it. But to follow just my ideas, we did the implant bed preparation inside the chin, and we enlarged the cortical part of this bone ring. And in the end, we used another tree fine to go into the counterpoint of the cortical part on the lingual aspect of the mandible and harvested a bone ring, which with a cortical part and a cancellous part. And here are the 2 bone rings taking a relaxing blood bath. And we use the bone rings as a template for doing our implants. And that was the beginning. And this is what we gained in a single step surgery. So we were very proud of this technique to this point. So this was after 6 months, and you see uneventful healing. We got a nice amount of tissue now to work with. And when I did the re-entry, I was quite happy because I had bleeding bone, and I had also bone on the implant shoulder. And that was for me, let's say, a very good stomach feeling, because we know that I enlarged the cortical aspect of my bone ring. And so I know that I have vital bone because bone was growing. And this was a good start for this prosthetic part now. And this is a final restoration. The picture is now 11 years old. The crowns have been redone after 6 or 7 years after an accident with a bicycle. And after 11 years, I can show you the follow-up of this huge case. You can see here we have enough bone on the buccal, also bone on the implant shoulder, which is important for long-term success. And this is the situation now after 11 years. You see the soft tissue is looking quite good, also from the lateral aspect. And after 11 years, I'm quite happy with this case and the patient as well. So this was autologous bone and bone ring technique. But it happens also that people are not really keen on getting bone blocks out of the chin or somewhere in the oral cavity. So the idea of my uncle was to invent, let's say, a prefabricated bone ring made of an allograft. So in the end, it's just a hip joint. And from this hip joint, we had this allograft bone rings. We used it in the same way we did with the normal bone ring technique, but without any harvesting. Here you see here a bone ring, it's 1 centimeter in length. You see, we have also did the preparation prefabricated for a 3.5 millimeter implant, and then you can do the trimming. It depends on the situation, how much volume you need. And now you see here also a similar case, also maxilla, frontal area, old lady with some, let's say, health issues. And she wanted to have fixed teeth, single implants, but she didn't want to have any harvesting. And that was a problem when you see the X-ray. So we have a big defect there. And to this point, I didn't know any solution without any harvesting bone to solve this problem. But it was in the beginning of the allograft rings. And when you can see here also the slides from the lateral and also from this direction, we have a big problem to solve. And now I can show you a short video, and there's lots of information inside also for further slides. Let's go. You can see here the defect. I enlarged the defect a little bit with a tree fine and a so-called planator. This is here now this prefabricated bone ring, 1 centimeter in length, and with a hole for a 3.5 millimeter implant. In the beginning, do the first fitting and see, yeah, it's looking good. And then we measure how much volume we need. A little bit of tea.
So have you drilled that out to make the defect fit the bone ring?
It's an own topic, but there are special instruments for it where we can do the implant bed preparation perfectly, and also the outer diameter of the bone ring, that you have a fitting like a cork into a bottle. So the fitting from the very beginning is just excellent. The big advantage of this allograft rings was to this time that you don't have to do any harvesting. And another big advantage was the consistency of this bone ring, because this allograft ring contains 20% collagen. And when you place your implant later on, you will see that the ring spreads a little bit. Because it spreads, you have a good contact to your local bone, and you have a very good primary stability from the early beginning. So you can see here, if you look at the bone ring, so some blood and liquid is coming out, so it spreads a little bit. The downside was you have to be quite fast, because when you wait too long, the ring can just fracture. And that was the downside, but it was quite good to handle. So you can see all the other implants are already placed. And on the 2-2 and 1-2, we did immediate implants. Place every implant subcrestally. Nearly done. Here we go. Subcrestal position. So, and from the early beginning, it was quite stable. Okay, so there was no need of any screws or other fancy stuff to get a good stability from the beginning on. So it was looking good, and we did all the vertical and also lateral augmentation in a single step with this block. But work is not finished yet. So now really the classic GBR comes. We got the small burr here, and we do some bleeding points in this area, a lot of them. That's what we've been told, that we have to do it. I don't know if it's proven if it works or not, but this was dogma. And of course, sometimes you follow the dogma. Sometimes you don't ask questions. So I removed the transporters, and then I had to do some GBR on the buckle. Here's the cover screw. See, subcrestal position for every implant. So now a very helpful tool comes. You see it's already stable, but to even stabilize it more, I used a so-called membrane screw. This is just a thin plate with a bigger diameter, and then we can give pressure to the local bone. Just put it inside the implant, that's it, like a gingiva former. But because of the flat design and the wide diameter, we can compress the bone ring to the local bone, and so we have just perfect stability. Easy, super easy, and very fast. Talk, talk, sound check. Good. Okay. So now the GBR comes. We have to soften a little bit the sharp edges. I used a big diamond burr for it. Just smoothen everything a little bit. Yes, and this is bovine material. So bovine and allograft. And this is collagen membrane. Of course, this is a normal procedure, like maybe you did it also with membrane and tags and using
Yes.
some bovine material.
Yeah.
So this is, you know, this is the way we start with augmentation. So the idea was with a bone training technique that we cover all the area with a bovine material, because we know that bovine material is not resorbable at all, to avoid resorption in the beginning of the healing process. That was the idea. So just not to use a very big layer of bovine material, only a thin layer. And now you can see here in this socket where I place now some of the graft material. Keep this in mind, because later on we show you how I will make it today, and it's even better today. So fill up the voids a little bit, do a little bit of smoothing of the buckle aspect, and even a little bit more cow to the place. So fitting of the membrane. Okay. Things are how to place the membrane is not, let's say, super exciting, but I want to wait with the video till a detail, because for me this detail is nowadays very important. And you can see that I remove now the cover screw very, very carefully, because I don't want to have any grafting material inside my implant. A little bit of shaky fingers, because you don't have to be very careful not to place any of these granules into your implant. And yeah, to have this in mind, today I do it differently. But this was, let's say, the surgery. To see the closure, you don't have to wait. But this is the X-ray post-op. Okay, and we see that we gained a lot of volume also here on the buckle. And after 2 weeks, uneventful healing, and I think no problems at all. So, and 2 weeks here, you can see we also, this one gingiva former is covered with soft tissue already. And after 6 months of healing, you see that we lost a little bit of volume on the buckle, but not that bad. Okay, so this was the situation after 6 months when we started with the prosthetics. And you can see here we have a nice tissue, also a bleeding tissue. For me, it was looking much better than any augmentation I did with bovine materials in the past, but it's not looking as good like I use autologous bone, for sure. Okay, but anyway, so we had a nice soft tissue design. No further augmentation from the soft tissue was done. So all this comes from the gingiva formers and the form of the bone block itself. Still, we see here some bovine material in the soft tissue. It will stay there forever. And then we placed the zirconia abutments, and finally we placed the crowns. The lady was 80 years old, and when we did the prosthetics, she was 81. And now she's 88, and so I have just a few years of a follow-up. That was a cone beam we did 3 years after loading, because we wanted to know what's happening on the shoulder of the implant, and it was stable. So this is now a photo I took after 7 years when she came to the hygienist, and it's still looking quite good. Okay, now we come to Porcelain. Miss Piggy is coming into place. Okay, so bovine is over, now pig. Okay.
I love the visuals.
Yeah, I love this case because there are so many techniques inside this case and so many details. And so I just call it the Fantastic Four. Because we placed an immediate implant, we did some socket seal technique and a sinus lift, and also placed a bone ring. This everything in one case. Let's have a look. So big lack of tissue, so major problem. And also from this perspective, not the perfect way to start. The idea was not just to do everything in just one-step surgery. So I removed the 2-4. I opened the flap, did the preparation for a lateral window, and did already the implant bed preparation in this 1 millimeter of nothing. And then I took the allograft ring, trimmed it a little bit, and I used this pig bone now here, because now pig is just modern and cool. And so I tried it out. And now I use the allograft ring, put it inside the sinus, and fixed it with an implant and the membrane screw. So I did vertical, I did stabilization of my implant, and also stabilization of my bone ring. So everything together works quite nicely. So this is, my friend, the membrane screw. Without this flat screw, that was not possible. So this is a very good tool for this kind of technique. This was the beginning. And here you can see what we did in single-step surgery. Lots of volume. If it's getting bone, we hope so. Okay, then I did a tree fine. I used the tree fine to measure the socket, where I removed the 2-4 and did the immediate. And I wanted to have a little bit more soft tissue, and I wanted to have a closed healing because primary stability was not good. And so I went to the tuberosity, used the treatment, and harvested a composite graft. So a little bit of soft tissue, a little bit of hard tissue, and then I placed it into the socket, did the sutures, and that's it. So uneventful healing, and I think it was after 6 months we did the prosthetics. The Pontic design is not good, absolutely not. But actually, the patient was super happy, so I was it as well. So sometimes it's good just to leave it in place and not to ask your lab technician to do it once again. Okay. Now, next pig, Miss Piggy case. We got a fistula on 2-4, the buccal defect, and the guy was a heavy smoker. So you see 2-4 with a fracture, and you see the soft tissue is not looking good. Lots of inflammation. The color of the soft tissue is looking awful, and also some pus here. Also, we see here from the occlusal view, also like pus. Fistula is not looking great. So what I did, I opened the flap because I have to clean everything. When I do immediates, I try to do it flapless. In this case, it was not possible. So we cleaned everything, and the rest of the bone was looking quite good and promising. So we did the implant, and the stability was quite okay. And you can see here from the lateral, the implant. Of course, nowadays I would do it different, but this is just interesting, the journey, okay? Mm-hmm. So implant, you can see here from the lateral aspect. And then I placed my abutment already in, and a healing cap. I followed the concept of one abutment one time. And then I filled everything up with, sorry, maybe you can see here on the slide now. Yeah, you can see the membrane I used, okay? This was also a pig membrane. So everything was pig in this case. So we covered everything with some granules of these graft material from pig, like GBR, but only with pig, not bovine. Uneventful healing, you can see here the membrane tags and the X-ray, and the healing was uneventful. This is just post-op with the healing cap on top, and after 3 months it was looking quite promising.
That's looking pretty good.
Yeah, we have a little bit kind of small defect on the buckle, but that's absolutely enough to work with. So this is now the abutment, and you can see here all the small piggies here laughing at me. Okay, so I then replaced actually the econometric crown on top, and soft tissue response was good. So this was after loading. You can see here the soft tissue, the loading. See here the anemia there, and it's the same picture after 1 year. So there's nothing changed so much. Yeah, that was my experiences with pig and the 2-4. So I think this is the last case with pig, and then we come to a new topic. You can here see here also a fracture over here, and my idea was that we not have big inflammation, just to open just a very, very small flap, because we can't see the root really good. And I just opened a small flap like here, and I did the separation from the root, because I wanted to work with the socket shield technique in this case. So I removed the root, but left on the buccal aspect one part of the root, trimmed it. So you can here see the shell, the bone shield, and the socket shield for the root on the buccal aspect. And then I placed the implant. There is no contact to the shield. You can see it from another perspective later on. So here I'm placing my abutment. I also followed here the protocol of 1 abutment 1 time. And then I did a temporary on top, filled up the voids with pig bone, and did some just 2 sutures. So that was the beginning. That was post-op picture. You can see here the shield quite good in this X-ray, and the voids are filled with this pig bone. And from the cone beam on this perspective, you see we have lots of material on the buccal. So should be a good outcome for the future. You can see the shield over here. And from this perspective. Okay, so this was after the healing, the abutment stayed there. So we followed the protocol 1 abutment 1 time. That was the beginning, and that was the abutment and the econometric crown and the final restoration in situ. So we have quite nice soft tissue design, and it was not a big surgery. And I like this kind of protocol very much. I do it today a little bit differently. I will show you a few cases of this later. But I was quite happy now with these kind of surgeries. So that was part 1. Okay, that was my let's say briefly short overview about materials I used most of the times. Now we come to part 2, and part 2 is of course EthOss. No, it's EthOss. It's EthOss. Okay, so part 2. The beginning of EthOss was like this: that a nice lady, old lady, very small, maybe on a very thin biotype. She had a denture in the mandible, and she wasn't happy with it. And but the only way to remove the denture was to placing implants and do lots of augmentation. And for her, it was not in her mind to do any harvesting of bone somewhere. And I didn't want to use bovine bone anymore. And so the idea was maybe we try something new. And because I didn't know EthOss to this point very good, I asked Peter. And I wrote on Facebook, is it possible to do lateral augmentation, also like bigger amounts, and use EthOss in a predictable way? And he said, go for it. Go for it. And you see here in the chat, 2 days later, I got my EthOss back in my clinic, and then I started the first case. Of course, in this moment, I didn't document so much, so I didn't took photos during surgery, but I have the X-rays. So the thin mandible, that was my very first EthOss case 2 years ago. You can see here in the cone beam that this very narrow mandible here the thing is, and this foramen over there, it's not easy. It's not possible to place any implants there in this stage. So lots of lateral augmentation has to be done. So this was the beginning. So not very promising. And my idea was to use some screws to get some stability on the lateral, and just to around the screws I placed EthOss, and no membrane, nothing. And then I closed the flap, and I was looking on my watch, and I said, "Ooh, that was quite fast." It was absolutely uneventful. So it was quite fun. So I didn't trust materials that people tell you it's getting hard, it's super easy to use, it's super bad, it's super cool, predictable. I said, yeah, can tell a lot, you know. But in this case, I had a very good feeling, I said, because everything went right and perfectly, you know. Then you see here the post-op cone beam. So that's just a video I took with my iPhone. Maybe you hear a noise from the back. Maybe this is my nurse. But you can see that a lot of volume we gained with this very easy surgery. It took me 35 minutes. It was really fast. So super good. And then we had enough bone, and really bone. You see here, this is bone now. This is not something artificial. We have a modulation, and it's looking different than in the beginning. And we placed the implants, or I placed the implants in the vital bone, and I was completely happy with it. This is the during the healing period, and it's looking very good and very promising. Actually, because I know that the schedule was the 8th of November, I asked the patient to come over for maybe a cleaning or something, just to a follow-up. That she didn't come. She said she's busy.
Yeah.
But maybe next time. But this was my first EthOss case I did. And afterwards, let's say a similar situation, but in the maxilla, a patient who was quite young, and he had some, let's say, trauma in the past and some bad stuff going on. There was a guy tried to do some augmentation, it completely failed. And we here now have the situation of 1-1 and 2-1 with big defects. And you can see here the cone beam from a lateral perspective. And when we opened the flap, there was not so much bone to work with. So many problems. The foramen was huge, huge. Could put a finger inside, it was huge. And we have defects everywhere. And we had also on the 2-1 area, tunnel defect here. This was just soft tissue. So there was not so much volume. So my idea was also to, like in the case before, it's just to use some screws, easy, super fast. And try to get, let's say, a guideline for the EthOss. And I used quite a lot of EthOss here and did the modulation of the bone. And that was the post-op picture. And we gained a lot of bone, you know. And after the healing period, it was looking very promising. So we were able to place the implants easy. And bleeding bone, this was after 10 days actually, when I removed the sutures. And this was, I think, 4 months later when I placing the implants and sent the patient back to the referring dentist. But this was the picture I got before installation of the crowns. And I think this is pictures I like to look at the soft tissue design. I'm not looking so much, and when I see pictures on the stages on the nice crowns, I like the soft tissue design and looking very healthy. And it was like not a big surgery, you know. So when I imagined to use Curie technique here, of course it's possible, and of course it will work. But I think lots of bruising and pain. He didn't have any pain at all. So again, it felt very promising for me. And I tried it now for different stuff. So let's say have a look at the immediate implants and an immediate provisional fracture. Once again, fracture, so many fractures. So this was a fracture, and you see also here the inflammation on the buccal aspect, like we saw with the 2-4 a few cases before. So a big area of inflammation there, and we removed this puzzle here, and I opened the flap just a little bit for cleaning reasons, And then we did the implant and filled up. Just first of all, we did also the concept of one abutment one time. So I placed my econometric abutment here in place and fill up now the voids with EthOss. And I was not so, let's say, trained in how to dry it to this point. So it looks like maybe trying to cook something and it didn't work. So, but the let's say to place it there and to dry it, that was, I think lots of training was needed for me. It wasn't completely other kind of working, but actually I liked it a lot. So I filled up the voids. That was a temporary abutment for a temporary crown. And here we have the temporary crown and glued it to the neighboring tooth and just used 2 sutures to stabilize the flap we opened. Here you see the post-op picture. And this is the post-op picture from the lateral view. The color of the soft tissue looks like Halloween, but we had this huge infection before, and after 3 months it looked much better. Sunshine again and nice tissue to work with. So I'm quite happy with it. And you can see this also from another perspective. You can see here the abutment. I don't have any particles of bovine or piggy bone around my abutment. That was also nice. And the soft tissue was nice, so everything was nice. And I placed the crown. Let's see here the pressure on the soft tissue. That was right after delivery of the crown, and very, very good. Now the final picture, and you can see here that all the voids are nearly gone, and you see the structure of the tissue around the implant, which is only bone. And this picture I liked a lot. So it was also felt again promising. Okay. Another case, fracture. So many fractures today, but this is my daily business are immediates. Most of the times we don't do so many full arches, so it's most of the time just 1 or 2 implants and lots of immediates. So the idea was to place an immediate implant and using the socket shield technique and go for delayed loading. So this is actually a case I did 2 weeks ago. From a man, he's living in the mountains and had to drive 2.5 hours to my place. And so everything should be working good because distance was quite very big to the office. So you can see here the situation of the fractured tooth. And I did the drilling and the preparation of the shield on the buccal aspect. Placed the implant. No incision, used EthOss again and get some liquid to it. And you can see a scan body here. And around the scan body now, I filled the voids with EthOss. And now maybe we remember the video when we saw the allograft bone ring, where I really, with shaking hands, placed the gingiva former and removed the cover screw because I don't want to have any of this bone graft material inside my implant. 3 minutes later, after drying a little bit, there's no problem anymore. It's no problem. You can see here it's quite hard already, and it's not titanium, it's not stone, but it's quite hard, and there's less let's say danger that you have some graft material inside your implant. So much more easy for me to deal these cases. Mm-hmm. This is the post-op picture, and this picture is from today, 2 o'clock, and that was after 10 days. It was a temporary crown, and we put the temporary crown into the implant. You can see here from this perspective, everything looks nice and promising. Of course, the contacts, that's very important. And
that was
what the final result will be.
Was that a Schwan BLX? That's the first one I've seen that wasn't an ankylos.
Yeah, it was. I was working only with ankylos in the past, and now I also do a little bit of prime tape, which is very, let's say, the child of ankylos and Astra EV. So the prosthetic part is Astra EV. So another defect, no fracture. 2.5. Okay, so let's have a look on it. So we have a big inflammation here. So there was no way to do an immediate here. Just removed the root, cleaned everything, and waited just for I think 7 weeks, 8 weeks. A little bit of defect here, but more defect on the buccal aspect. First sight was quite good, but when we opened the flap, there was quite a big defect. Not a big deal, but a quite big defect. So augmentation has to be done. And of course, the protocol is nearly the same, like we saw in the past. Place the implant subcrestally. There's also ankylose here, and fill up the voids. EthOss. Place just a thin gingival former and did the suturing. So no big deal. So super uneventful healing. So this is after suturing, very fast, very easy, no big deal. And this was from the lateral. And this is this is a post-op X-ray. Maybe we have a closer look around the implant and the void, or the area around the implant, and what happened after 2.5 months now. So it looks different. It looks like healed, like really healed bone. And we did the impression, but the drone is not in the patient's mouth, so I can't show you now the pictures of the final result. But when we see here the bone around the implant and how the soft tissue was looking like when we did the impression, there must be just everything is very nice. So, and no danger for anything. I see I'm quite good in time, actually. So this is the last case I show you, and this is I done in September. The complexity was quite high because it was the mother of my my clinic manager, and she's also our hygienist. So everything should run the right way. So she had a fracture of a 2-1, and the idea was to use a socket shield technique, immediate implant, and but did a delayed loading. And one thing was she really had all allergies in the world. It's fantastic. So this is the beginning. Okay, so you see here the fractured root. You can see here the situation inside the mouse. We didn't wait so long after the fracture, so we did the appointment quite fast because I didn't want to have any inflammation there, to keep all the tissue we have. I didn't want to make any incisions, nothing. So this is from the occlusal perspective. So I did the preparation of the shield, and then did my pilot drill a little bit to the palatal aspect, and did the place the implant and left a nice gap between socket between the shield and the implant. Again, filling up the voids with EthOss, and wait 3 minutes, remove my transporter and put a gingiva former in. Life can be sometimes so easy. So just a stock abutment, nothing fancy, and just one suture just to fix, to adapt the soft tissue a little bit without big pressure. So that was the beginning, right after surgery. And this was the post-op picture. We can see here the voids filled up with EthOss, and we got to also see the shield here on this X-ray. And after 3 months of healing, surprise, surprise, it's looking very good. Beginning, 3 months of healing, no incision, no soft tissue augmentation, nothing. It's only immediate EthOss. And now look at this picture. You can see it's about 2 months of healing, 2.5 months of healing. You still see a little bit of EthOss, but it disappears. And the soft tissue design is just amazing. And the final restoration also was quite good. So look at the soft tissue design from this perspective. I like it very much. Look at the texture also of the soft tissue, the color, the support, the nutrition, everything looks good. So this was the final restoration right after delivery from the lateral perspective. And I don't have a long follow-up. We did this, the final restoration in September, but I got at least 2 months of a follow-up. This was after 2 months. So everything looking just perfect and very promising. And this is my favorite pictures are always taken from lateral, because you can see the shape, the color and the texture of the soft tissue the best. So this is now my protocol for immediates. It's very fast, very predictable, and I really love it. Ooh, we can't. So the conclusions. So first up, I think it's EthOss for me is now a very promising alternative to all materials I used in the past. Of course, I didn't try anything yet, but I still want to push the limits a little bit, look where it leads me to. But at the moment, I'm really happy. So, and at the moment, it's the only material I use. So the idea of something which is fully resorbable is for me one of the most important aspects with EthOss. I'm now at an age where I concern about patients you treated maybe 10 years ago. You still see them. So if you do things maybe bad, you see them in the future and they will ask questions. And in the past, I was not looking so much into that because I was young. Didn't have my own office. I worked in this place and in another place, and I didn't have this complaining because I didn't have this long follow-up. But if you have a material which is fully resorbable and you have maybe also an implant system you trust, then you have, let's say, vital bone around your implant. What should happen? What should happen? So maybe some mucositis later on because cleaning is not good, but we don't will have any problem caused by our graft material. This is for me a key factor at the moment. It's vegan friendly. People say, oh, vegan. Now he shows some tomahawk steaks and now he's talking about vegan stuff. At the moment, I have lots of vegan patients and they ask for vegan stuff. And so in the end, I say, hey, this is synthetic, it's vegan. Yeah, it's good. So you can treat also all this people who are doing yoga and eat vegan and they're happy and the sun is shining. You don't have any big talkings with them with bovine or pig materials. No issue. So for everybody, okay? It's fast. Okay, so we don't use any membrane. We don't need a membrane tags. It's not needed. Yeah, we just need a little bit patience, 2 to 3 minutes to dry it a little bit, the material that it's getting so hard that you can close the flap. And you know, sometimes you just have to be 2 or 3 minutes patient, and that's it. So sometimes you have to be patient when you took an impression. You have to be patient there as well. So in this case, only 2 to 3 minutes and then you're done. And the other thing is, it's not only the way to work with it. From a biological perspective, when you open a flap, your bone has no nutrition at this moment. The longer the flap is open for the bone, the worse. So if you shorten the treatment time and you don't cover everything with a membrane, to avoid the contact of your periosteum to the bone, I think then we have a big advantage in healing. So we have a much faster nutrition, much faster blood vessel income there. So for me, this is also a major point we have a faster healing just because of this. Okay, so it's highly predictable. I have now 2.5 years. I'm working 2.5 years with EthOss. I didn't have any, let's say, problems with it. Of course, sometimes you have a dehiscence, but even then, it was no deal. So it was looking very, very good. And because of the material is so, let's say, bio-friendly in a way, I can't describe it. And I don't want to show you any histological slides. Can somebody, or Peter can show it to you. I have lots of histological slides. I think it's working very good, even when you have a problem. It's cost effective because we don't need any membranes, we don't need any membrane tags. Maybe we can avoid a second step surgery to remove titanium membrane. So for me, this is cost effective in a way. So we can work faster, predictable, and cheaper. And one of my favorite topics at the moment is also like immediates and socket shield. Because for the patient, it's very nice to do not any incision and do not augmentation of putting a little bit more Geistlich material on here and there and a little Geistlich on top. I think today nobody has, or everybody has some problems with money, I think, many of our patients at the moment. So if you can make very good surgery with a very good outcome, predictable outcome, but with less money, I think this is for me just also a key factor. And I love working with it in this way. It's safe. There's no infection, no problems or allergies are known. So it's safe to work with and easy to use. I think we saw this in many cases before. And we have a good range of indications. We can also solve, let's say, bigger defects with this material. And we'll see how far we can push the nhưng. Okay, I think the two cases we saw in the beginning were quite promising if you have also bigger defects. Okay, so, but I want to show you also, I don't so much into citations and showing publications, but this was very interesting. So this is a guy, Mark Boner, he's from Switzerland, and he showed in his paper that better TCP is synthetic, it's osteoconductive, osteoinductive, and the resorption is just done by cells. So it's super, the support of the biological of the host bone is just perfect. And this makes it to one of the most promising and most potent bone graft substitutes we have in the market. And it was just brilliant. And when I see this, my conclusion is, what the hell? Maybe it's the ideal graft material, maybe. So, and I have to ask myself, is my journey now over? Or my quest to the best graft material? I don't know. But at the moment, I take a pause because I'm really happy. So I'm really happy with it. So I have to be finally thankful also for Peter to bring such a good material to the market. It's really fun to doing surgeries with it. But sometimes it's also important to think out of the box. Everybody of us went to university somewhere and had a mentor here and there, listening to lectures, listening to friends. And everybody of us has his journey and his stories to tell. And everybody has this kind of experience here and there. So, but sometimes it's important to think also out of the box, ask questions. And I was never thinking about using a synthetic material before I had this situation in the 2.5 years ago. So sometimes we have to ask ourselves, are our protocols right? Or can I improve something? Or why do I do this all the years, every time the same? And this is for me also something, when you don't ask questions and don't maybe change your protocols, there will no improvement and no progression. And this is really bad. And the last thing I want to show you now is a very small video. I showed it so many times, but I love it so much. It's from a photographer from California. And his job, imagine that, he's traveling to the most beautiful places on this planet, the best beaches, and taking photos of bikini models and of surfers and of nice hotels. Everything is just simple nice. And he was just sick of it. He couldn't see this nice stuff anymore. And he was also very much into surfing. So what he decided is to bring a small group together and travel to the most awful places on this planet. Let's have a look. Never stop exploring. So he went to Iceland, to Norway, to the Lofotes. And they were searching. They did exploring new ways, new waves also. And this environment, I mean, this was really by far out of the box. You know? but in the end, if you believe in this quest, in this journey, suddenly you can really find beauty and maybe perfection where you didn't thought this is possible. Look at the final picture now. Nobody could imagine to surf on the polar lights.
Yeah, that is pretty serious.
Sometimes we have to, don't stop exploring. We have to ask questions. We have to progress. And these are my final words to you. Thank you for your attention. And it was a pleasure to share some knowledge with you. Thank you.
Wow, Marco, that was sensational and exceptional. A really nice combination of seeing sort of conventional approaches and your more recent approaches. I mean, I really appreciate listening and hearing to someone that's got so much experience in so many different areas of augmentation.
Yeah, I mean, it didn't show everything, but it was just, let's say, an honest compression, what I did the last several years. And of course, when I see now cases like also with the rings and stuff like this, I don't do this so much anymore. What I try today is just to reduce risks, reduce surgery time. And 10 years ago, it was the difference. You know, I wanted to have the bigger, the better, the worse, the better. So, and now I'm coming to the point where I'm thinking out of the, let's say, the eyes of the patient more. He don't want to have these big surgeries, and he don't want to harvest bone here and there. And this is also maybe one point where what you don't see on the big screens, on the big stages in this world, you see beautiful cases of the Curie technique, but you never see the post-op pictures, the swelling, the bruising, you never see it. And I think the patient went through hell for just a couple of days. The final result is perfect, no matter what. So, but it's a big surgery. And what Istvan said, even if I'm the biggest fan of him, but in this point he's right, it's not necessary. It's not necessary. You have alternatives, and the alternatives are promising and predictable. And this is something, out of the box thinking as well. Not playing all the game with dogma. There's enough dogma in the past of the big names, and now it's a new chapter.
Yeah, I mean, you touched on those with referencing the simplicity and the speed in which you can.
So I can't hear you anymore at the moment.
Sorry, one of my speakers on my laptop was blown during your presentation, and it was sort of playing. It was messing around through the presentation. We've got a couple of questions actually. Can you hear me? So there was a delegate called Michael asking if we could, or if there was a requirement to do two-stage surgery.
Stop the sound.
There you go.
Okay, I think now voice is better now.
Try now.
Yeah.
So Michael was asking if there's a requirement to do a two-stage surgery with EthOss, as he was finding some of his cases using healing buttons.
I know, Arthi, I'm still also in the, let's say, in the finding, try to position myself or to what can I do and what not. So, and I also saw the cases of Peter where he do the push-ins, and he every time he has success. I never tried. But this is also something like out of the box thinking. And this is also out of the box thinking, do you need primary stability? No, you don't need it. Not that much, like we were talked to. So, because what happens in a socket when you remove a root, it's bleeding, you have a blood clot, and then you have bones. And you don't have, it heals. So if you put an implant in the socket and maybe it's only maybe 6 newtons of stability, which is nothing.
Yeah, you really just have to make sure that the screw channel is pointing in the right direction.
Yeah, that's it. That's it. And then it will heal. Maybe it takes a little bit longer.
The amazing thing with those cases is that when we were measuring ISQ, we were getting better scores for the ISQ readings for those push-ins than we were for normal implants.
Freshly formatted bone.
Yeah. I mean, it's all to do with the dieback that comes from a little bit of pressure that the bone is under. But,
so I don't think so. That is real. You know, I didn't collect it to now so many cases, but maybe if there is a webinar in the future, we will see. You know, I have to find out also where my limits are, where my stomach feeling is good. But
yes.
in the past, it was like also sometimes did cases where I see, oh, really. Yeah, and I wanted to go through it, like this Fantastic Four case, which was quite complicated, but finally it was good. So as long as you trust your knowledge and your hands, many things become good.
Yes. Have we got? Are there any more questions that anybody would like to ask? We've got the questions and answer pro forma is up. There's one here. Shamir is asking, how long can you wait to place an implant in a case of large DBR with EthOss?
I waited every time 3.5 to 4 months, and the tissue was looking very promising. Maybe you can do it earlier. Maybe later is not necessary.
Yes, I mean routinely I probably wait 10 weeks.
Yeah,
just what we're used to waiting. But yeah, a little bit longer is no problem. There you go, see if any more come in. Yeah, I appreciate your presentation. That was great.
Thank you very much. It was fun.
I love this little logo as well, the swan.
No Z in the end, please. It's just a luck that you have. You can use your name with a logo. Yeah, that's it.
Yeah, that was very good.
Thank you.
I'm sure we will see a few more from you.
Yeah, I hope so. I hope so. I think most of the people got maybe a nice glass of wine now. Try to relax and enjoy the evening.
There's a couple more questions coming in there.
Oh, okay. Let's go.
Can I use EthOss in ridge splitting to fill the gap?
Of course.
Yeah.
No doubt.
Another one here. Can I use EthOss in sinus lifting?
Of course. I do it now on a daily routine. Perfect.
Yeah.
Best material.
Hello. Once I made a horizontal augmentation with EthOss in the maxilla, region 1.4 to 1.6. After 3 months of healing, the material just disappeared. Can you perhaps find a reason for this? I'll mention that the residual bone of maxilla was quite flat. Thank you. That was from Lua.
Maybe flap design, less nutrition afterwards, can be pressure. We don't know our patients so good. We don't know what they are doing at home. If maybe you do a horizontal augmentation and the patient was wearing maybe a removable denture, you can lose everything. So I didn't have this that I lost anything when I had, let's say, I had dehiscence and my augmentation area was partly exposed. The healing took a little bit longer, but I never had any problem with that I lost something. So
I mean, with the first case you showed where you were using those stabilization sort of tenting screws.
Yeah.
I mean, that's a good demonstration of using something to give your graft a little bit of something to help stabilize it.
Yeah, I think if you just use something on top, even if it's becoming hard. I mean, it's not like you're using like you're putting composite on a tooth where you use the etching before and the bonding. So of course you have a connection to the local bone, but if you have too much pressure or let's say I had some problems in the past where I lost everything just because I just took wrong incisions. So I really cut away the nutrition. And then I lost everything. So I also had this kind of failures, but I haven't seen any failures yet with EthOss. I hope it will be the same in the future, but on my experience, if you lose everything and you have no problem with infection, The most problem is movement and no stability and pressure.
And these are things that we know about bone growth or augmentation that lend themselves that we can take from GBR skill sets as well, with stabilizing the graft.
Yeah.
Next question, Thomas. Thank you, great lecture and very enjoyable to watch and listen. When we dry the EthOss, it appears to have a partial set. When you close the flap immediately, the blood contacts and the set seems to reverse. It becomes soft again. Is there a problem with this, or is that to be expected? Thank you.
I had this a few times when I was not happy with my flap design, or I was not happy with my sutures, and I opened again. I give you right. The surface was a little bit soft again, but what I did, I used some gaze again and dried it a little bit and did more sutures, and that's it. So I never had any big problems with it. As long as underneath the big volume is stable, I think there's no problem.
Yeah, I think, the only things I can add to that are making sure the periosteum is raised enough, rather than trying to raise it at the end of surgery. You sort of raise it at the end of surgery, you can cause a little bit more bleeding. Yeah, and it's a little bit harder to control at the end. Easier to try and control your bleeding at the beginning.
True.
Another one here. EthOss should be covered with mucosa or can be left exposed?
I would cover it. So maybe I don't have any experience yet if you just do, let's say, socket preservation without any membrane on top or any composite graft on top. I would say the past I didn't like the contact of, let's say, the mouth is like the worst case of bacteria in your whole body, you know. And you can see also how you can have problems when you remove a root. It's very simple, and maybe the patient is a smoker, you know, and after 3-4 days he has massive pain and your blood clot is completely gone and you have these alveolitis sicca, and then you have to deal with that. So as long as it's possible for me, I will cover it. And I don't see let's say the big advantage to fill just a socket with any biomaterial. For me, it's just better to use it if it's needed later on. And as long as I can go for immediates, I will go immediate, and then I have maybe a gingival foam on top or something comparative. But I will not leave it open in a socket. I don't.
Yes, I have a preference to putting something over the top of it. Again, I've seen people leave it, and I've come back to my cases when whatever I've put over the top of it has disappeared, and the EthOss has been completely solid underneath. Last question, should EthOss be stabilized with screws, or can I use a titanium mesh?
Of course, you can use a titanium mesh, but in the end, the mesh is, let's say, not so easy to use, not so fast, and you have to raise a bigger flap when you want to remove it later on. So the second stage surgery or the re-entry, you have to raise a bigger flap, and the more you raise a flap, the less nutrition you have, the more scar tissue you have. Of course it works, and it's a perfect tool to stabilize everything. But EthOss itself is quite stable. So for me, there's no need to use a mesh. So if you have maybe some screws, it's enough, and it's much faster, in my opinion.
Yeah. And that was the last one, Marco.
Okay.
Last question. So thank you very much for a brilliant presentation.
Yeah, thank you very much. It was really fun.
That was fantastic. I enjoyed that.
Thank you for the invitation and the chance to share knowledge.